Part of the lecture is on blood disorders. Some of the common lab tests that are done to check for blood disorders. We do a type and cross if the child may need blood. Clotting studies, coagulating factor concentration, CBC with diff, hemoglobin electrophoresis, iron and lead levels, retic count, and serum iron. Those are all things that we talked about in the previous lecture. Big thing I want you to know about CBCs is what is involved in a CBC. RBC count is the actual number of counted RBCs. That tells us if there is a problem with the body manufacturing red cells. Hemoglobin and hematocrit. Hemoglobin is the measure of protein made up of heme and globin, and hematocrit is an indirect measure. They actually triple the hemoglobin. So hematocrit should be roughly 3 times the amount of the hemoglobin. RBC indices, meaning what do they look like? Are they the right color red? Are they pale? Are they small? Are they large? White count, number of white counts in a volume of blood. Platelet count, again, platelets per volume. And mean platelet volume, a measurement of the actual size of the platelets. So here's this question that helps you realize the huge differences between children and adults. The nurse is assisting with a CBC for a 6-month-old infant. What's the normal range? Well, you're going to want to say maybe C, maybe D, but it's actually B. Normal range goes up to 19,000. So realize that the young children, if they come back with if it's a baby and a white count of 15,000, that doesn't automatically mean infection. Iron deficiency anemia, some of the risk factors for this are maternal anemia. I'm not going to read everything on here, but you get the idea. The big thing I want to point out is cow's milk consumption before 12 months of age, certain diets, chronic infection, inflammation, chronic or acute blood loss. Those are big things. Also, lack of iron supplementation in children after age 6 months. So if that's the problem, then the therapeutic management is iron supplementation. So what you're going to see with these children is irritability, headache, dizziness, weakness, shortness of breath, pale, fatigued. Some of the more subtle signs are they just don't eat well. Pica, they're eating things that they're not supposed to. Muscle weakness and unsteady. So we're going to observe the child for fatigue and lethargy. We're going to inspect the skin and conjunctiva and the oral mucosa and the palms and the soles for pallor, for paleness. Spooning of the nails, and you can see what that looks like on figure 46.6. Get an oximeter reading. See what their pulse ox reading is. Are their SATs 95 or are they lower? Is there a rapid heart rate? Because that's the heart rate tries to compensate for the low hemoglobin. Same way with the heart murmur. And check the tummy for splenomegaly. The spleen will enlarge because it's trying to compensate again. So you're going to see a decreased hemoglobin and hematocrit, decreased retic count, microcytosis, meaning they're little tiny red blood cells, hypochromia, meaning they're pale, decreased iron and ferritin levels, and an increased free erythrocyte protoporphyrin level. And again, that's compensation the body's trying to do because there's such low levels of hemoglobin. So promoting safety gets its own slide. These children have anemia, they're tired, they're more prone to falling, they're more prone to infection. So we really need to keep an eye on these kids. Things to help them get better and then prevent down the road. Red meat is the easiest thing for the body to absorb. Tuna and salmon, eggs, tofu, enriched grains. If you've got a vegetarian, keep in mind the lower part of this is perfect. Tofu, enriched grains, dried beans, peas, and fruit. Leafy green vegetables are great, and iron fortified cereals. If they're going to be on iron supplementation, prophylaxis is 1 to 2 milligrams per kilo per day, up to 15 milligrams. Mild to moderate iron deficiency, it's 3 milligrams per kilo per day in 1 or 2 doses. Severe is 4 to 6 in 3 doses. Big thing to know about iron. If they're taking liquid iron, it's very important that they use a straw or nipple, depending on the age of the child, of course, to get past the teeth, because iron will actually discolor the teeth. If they are getting it by injection, different preparation, of course. It's an IM injection, and you need to do what they call the Z-track method, where you slide the skin over, inject, and then let the skin slide back. Otherwise, you can actually leave a mark there from the iron. A couple other nutritional deficiencies, folic acid and pernicious anemia. You do need to know the difference between the two. The causes are different, the treatment's different. Folic acid, it's a low dietary intake of green leafy vegetables, liver and citrus. Also, if a child's on Dilantin or has a parasitic infection, that can cause folic acid deficiency. Sounds like a really good test question. Where pernicious anemia is simply a deficient in vitamin B12. So folic acid, we're going to see what kind of risk factors they had, and the list is there. Pernicious anemia, a little different there. And here's the big thing too, is they call it a beefy red tongue. Smooth texture and bright red color. That's specific to pernicious anemia or vitamin B12 deficiency. And your labs are similar, except that you're going to have a low vitamin B12 level with pernicious anemia. And management for folic acid is more green leafy vegetables. Make sure the parents comply with that, whereas pernicious, you're going to actually give them B12, potentially injections, monthly injections, throughout their life, probably. So, B12 deficiency is known as what? We just said it. Pernicious anemia. Lead poisoning, health history. We need to find out, is the child not eating? Are they fatigued? Do they have tummy pain? How are they doing in school? Behavioral problems, irritability, hyperactivity, or lack of ability to meet developmental milestones. If that's happened recently, did they meet them and then are falling back? You know, first thing we want to consider is autism, but we need to check for lead poisoning. It can be something that we can do something about. Screen children for risk of exposure to lead, and blood levels greater than 10 require conscientious follow-up. And note if they're pale in the skin too. So some of the sources of lead poisoning: paint in the home built before 1978, soil where cars use leaded gas have been in the past because it can get into the soil, glazed pottery and stained glass, lead pipes. Parents can bring it home on their clothing from work, certain folk remedies, and old painted toys or furniture. Also, I want to point out here too that if you have a sibling who has lead poisoning, all the family should be checked. All right. Complications of lead poisoning. Remember, a normal reading is 0. Children should not have any lead in their blood. So if there's lower levels of lead in their blood, you'll see some behavioral problems and learning difficulties. Kind of really hard to pinpoint. You know, that's kind of vague symptoms. Higher levels when you start seeing the big encephalopathy and seizures and actual brain damage. Hopefully we can catch on earlier rather than later. So prevention of elevated levels is critical. Screen children, this is done at 6, 9, 12, 18, and 24 months, and again at 3, 4, 5, and 6 years of age. Table 46.4 gives recommendations for how we treat them based on the lead levels. Another thing we need to do is get them to remove old paint. If they are renting, this needs to fall on the landlord or whoever owns the property to get that fixed. Educate families how to prevent exposure to lead. Child's undergoing chelation. Chelation therapy is when they give a drug that pulls the lead to it, and then they excrete it in their urine. So it's very important that they have good renal function to do that. So that's why they get adequate fluid intake and monitor their intake and output. If they're very elevated, they may need to go to a cognitive deficit or to developmental learning center where they know how to handle that kind of issues and help the kids get back on track. Aplastic anemia is failure of the bone marrow to produce cells. Remember, the bone marrow usually spits out red cells, white cells, and platelets. So what happens here is the bone marrow just plain quits, aplasia. It just stops working. Pancytopenia means that all blood cells stop being produced. Again, red cells, white cells, platelets. Most cases are acquired, thought to be immune-mediated response to idiopathic. They don't know why. Could be environmental toxins. I've seen it associated with viruses myself. Myelosuppressive drugs and radiation can also do that. So children who are undergoing treatment for cancer are at great risk for aplastic anemia. You do need to know that Fanconi's anemia is specifically an inherited type of aplastic anemia, and it's an autosomal recessive disorder. So we don't see it real often, but it is out there. Severe form, you're going to see a granulocyte count less than 500, platelet count less than 20,000. Normal is 150 to 300, depending on the labs. Retic count less than 1%. So the body's not putting out retic count, tells us red blood cell count. Platelet count, that's our platelets, obviously. And granulocyte is telling us our white count. They're just not manufacturing these. If it's non-severe, your platelet count will be over 20,000 and retic count over 1%. And complications, of course, no white cells, you've got overwhelming infection. Hemorrhage from the fact that their platelet counts isn't working. Infection is from white count, platelet count, hemorrhaging, and also the fact they don't have any red cells too. So they start bleeding and there's nothing to stop them from bleeding, and they don't have much blood to begin with, so these children can die. Therapeutic management, if it isn't resolving pretty quickly, they will need to undergo a hematopoietic stem cell transplant from a human leukocyte antigen HALA matched sibling donor. Big problem if you're an only child. Immunosuppressive therapy or high-dose cyclophosphamide may be given. These kids are actually put in protective isolation to make sure that they don't get anything when they're in the hospital. Determine the history of exposure, history of bleeding, epistaxis from the nose, gingival from the mouth, increased bleeding with periods for female adolescents. Anemia can lead to headache and fatigue. They can have ecchymosis, that's bruising. Petechiae or purpura, those are little pinpoint spots or blue splotching. Oral ulcerations, tachycardia or tachypnea. You also might see guaiac positive stools and blood in the urine, and severe decrease or absence when they do a bone marrow aspiration. They just don't get anything out. Safety, prevent injury, stool softeners to help them be able to poop without straining. Only irradiated leukocyte depleted packed cells if they need blood transfusion, which they will, and platelet transfusion. So this helps limit the potential for reactions to it. And if they do require a stem cell transplant, that's a whole issue itself. All right, sickle cell disease. We see this in larger numbers in the African American population, but it can be anybody, so don't make assumptions. Significant anemia caused when the red blood cells sickle, and see that little picture where it almost looks like worms there. That's sickled red cells, and the red ones, spots, are what a normal red blood cell should look like. So sickling, if somebody has sickle cell anemia, there are certain things that trigger it. Infection, fever, acidosis, dehydration, physical exertion. A big one we see this time of year is excessive cold exposure. So they're going outdoors, getting cold. Change in temperature extremes can really set off a sickle cell crisis. And hypoxia, if they just aren't getting the oxygen that they need. So some of the things you'll hear, the terms you'll hear, vaso-occlusive crisis is when the red blood cells sickle and then get stuck in the small vessels of the body, causes a traffic jam, worse than 24/75 split. And they accumulate there, and then they cause pain because the joint, it's most often at the joints because those are the smaller vessels, and it can cause ischemia. It can cause the area to die, and of course that hurts. So pain is a real thing in sickle cell. And I know people who work, nurses who work children's ER, kind of start going, they're just here drug seeking. And there may be an element of that, but there has been a history of chronic pain with sickle cell. Can occur any part of the body, most often in the joints, causes increased metabolic need. Then we hit this vicious cycle. The heart goes up, heart rate goes up, respiratory rate goes up. So that leads to further sickling, which leads to more tachycardia and more tachypnea, and we've got to break that vicious cycle. Another thing, and this is the thing that most often kills our sickle cell patients, is acute chest syndrome. And what happens is you have those sickled cells clumping in the lungs. And so you get decreased gas exchange, get hypoxia, more sickling, again, that vicious cycle. It's the most common cause of death. There's also something called sequestration of the blood in the spleen. The spleen is where these red cells are destroyed, and so the spleen gets enlarged because there's so much abnormality there, and that causes abdominal pain. And the hemolysis, that's chomping of the red blood cells, leads to further anemia. Increased activity of the spleen leads to splenomegaly. The spleen is overworked, then it gets fibrotic, so hard and crunchy, and then it quits working, atrophy, it kind of dies away, but it's still enlarged. Functional asplenia, where the spleen just isn't working the way that it should, can develop as early as 6 months of age, and it occurs by age 9 in 90% of sickle cell disease kids. So this is a really crummy disease. Therapeutic management, usually we wind up, if they have severe problems, we wind up transfusing them once a month with packed cells to keep their hemoglobin and hematocrit up. There is discussion about transplant with these kids. Some successful, it's not the standard of care as of yet. Health history, we need to find out what set this off and examine the things that we've just talked about. This is their labs. Hemoglobin baseline is usually 7 to 10. Will be significantly lower with splenic sequestration or acute chest syndrome or aplastic crisis, because these kids can go into aplastic anemia also. Retic count is hugely elevated. You'll see sickle cells in the blood smear. You won't, but the lab will, and you'll get the report back. Platelet count is increased. Erythrocyte SED rate is elevated, and they're going to have abnormal liver functions. Educating the family and child on how best to manage. Also, fluids are very important. Keeping the kids well hydrated helps get those sickled blood cells on through the joints. Realize sickle cell is a genetic inherited disorder from both parents. This is a little slide here where you have both parents are carriers of the disease. So every pregnancy, if both parents are carriers, there's a 25% chance the child will be no disease at all, 50% chance they'll be carriers, and 25% chance that the child will have sickle cell disease. And so genetic counseling is very important with these kids. We want to prevent infection and support the family and children. Thalassemia. This is, your book says African American, but it's high in the Mediterranean group too. But again, there's lots of intermarriage now, and so you can't assume anything from anyone. You need to have a good follow-up and good checkout. Now there's alpha thal, that's what that little sign means, alpha. Synthesis of the alpha chain, it's much more rare. Beta thal is the most common. Beta thalassemia minor is simply trait. They can have a little bit of anemia, but usually no treatment is necessary. If you have intermedia, these kids will need potentially monthly transfusions to have good quality of life. And if they're major, they're going to need medical attention, blood transfusions, iron removal, and these kids are candidates for a transplant. So we monitor their H&H, give them pack cells, monitor their iron levels. These children may need chelation. Remember, I talked about lead and chelation. This is iron and chelation. It's a different drug used that goes in. It's usually an IV infusion, and it kind of magnetizes, not really, but it draws the hemoglobin to it and then carries it out through the kidneys so that it's taken out of the body. Usually these kids are diagnosed by 1 year of age. They're pale, jaundiced, they're failure to thrive. Remember, they're not growing the way they should, and they have enlarged livers and spleens. And so pack cells and educating the parents how to deal with all this is important. And here's your lab testing. I'll let you read through that. G6PD, fairly rare. History, including fatigue, foods to avoid, inspect for pale, check neural content. Here's the key thing. T-color urine is fairly common in this because they are blood cells, again, are being excreted in the urine. And because of that destruction of red blood cells, you have the splenomegaly as well, which of course you're going to see anemia as well. So oxygen, usually there's a triggering agent, and so we help parents to avoid the triggering agent so that it doesn't happen as often. This is idiopathic thrombocytopenia purpura, ITP, acquired. This is a good picture of purpura. Signs and symptoms, you have petechiae, which is pinpoint hemorrhages, and purpura, which is the larger purplish areas. And also you have some major, you can have some major bruising. Platelet count is under 20,000. This kid looks like they're abused, but they actually have ITP. It's associated with a viral or bacterial infection. No specific treatment within a short period of time. A little longer, there is a treatment that they can do. History of joint or abdominal pain, watch their blood pressure, inspect the skin for those rashes that you saw, document where they all are and how big they are. Palpate the rash, palpate the joints for tenderness, abdomen for tenderness, any blood in the stool. Again, they're going to have cherry or tea-colored urine potentially because of urine in the blood. And serum IgA levels may be elevated. So it's treating the symptoms. They may need analgesics. If normal renal function, keep them well hydrated. Note the color of the urine. Teach the child and family about therapy. Check the volume and frequency of urine output. Big thing here, often we give the children IVIG and 2 to 3 day, they come in every day for 2 to 3 days, and that actually coats the platelets and protects them from being destroyed. And so the children may get this once a month for a while. If that doesn't work in the long run, they may do a splenectomy so that that doesn't happen anymore. Watch for bleeding, no contact sports, no aspirin, no vaccinations, no allergy desensitizations. Otherwise, we don't want to go sticking them when they're could bleed all over the place. DIC, disseminated intravascular coagulation, and I'm sorry this is so long, but we need to get this done. Occurs when the increased clotting in some areas of the body. Usually it's secondary to another illness like cancer or an inflammation or infection. What you'll see is petechiae and purpura, blood in the urine. You're starting to see a pattern here. Persistent oozing. These kids are mortally ill. 50% survive, which means the other 50% do not. I have worked with this. It's devastating. Provide nursing care related to the triggering event. Usually they're in the intensive care unit with this. Apply pressure, elevate the affected body part if possible. Neurological deficits, anticoagulation therapy. possible. I know that sounds kind of crazy because they're bleeding everywhere. Well, what is happening is the body is over clumping there, it's coagulating, it's causing clots in one area of the body, and then you have bleeding profusely from other parts of the body. But it is treated with heparin to help decrease that clotting. And these just kids are very, very, very ill, often on ventilatory, they're on a ventilator. Clotting factors and platelets, changes can occur rapidly. These kids are terribly sick. All right, we're on the downhill course. Hemophilia is a deficiency in one of the clotting factors. Hemophilia A and B are X-linked, meaning the mother passes it to her son. So most of the time it's boys that have this and not girls. Factor VIII deficiency is called hemophilia A, and that's the most common. Factor IX deficiency is hemophilia B, or Christmas disease. And then there's a hemophilia C, which is kind of related to von Willebrand's disease, and this can be in both men and women. Mild factor is 5 to 50% of their factor. They have that is considered mild. 1 to 5% is moderate, and if they have less than 1% of the factor that they need, then it's called severe. And what happens is these kids get injured, and then they'll start bleeding. So imagine, a toddler who's walking and falls down, hits their head or their knee or their elbow. This can cause a big bleed problem, and these children can actually die if it's at the head. So they give them factor. Prevent crippling effects of bleeding, immobilized during the bleeding episode, genetic counseling. We had a set of boys come in to the clinic where I used to work, and they didn't find out until the one boy was a little over a year old that he had hemophilia, and by then she was pregnant with her second child, and he was born with hemophilia. So these kids come in, moms can learn to give factor. Now remember, if it's a factor VIII deficiency, they're going to need factor VIII. If it's factor IX deficiency, they're going to need factor IX. And so back years ago, this was collected from many units of blood to get these factors, and that's why we lost a whole almost generation of children who had hemophilia to AIDS because they contracted AIDS. And this was back in the 80s when they still didn't have a good treatment for it, and it was very sad to see this. But now kids do well. It is manufactured factors now rather than from blood, and so these kids do real well. But every time they get a bump or a bruise, they may need to come in for a factor infusion. It's given IV. It doesn't take real long, not particularly fun. You have to start an IV and insert the factor and watch them for a little while afterwards, and oftentimes send them home. So what you'll see is, of course, bruising and bleeding, and a PTT. Strengthening exercises for muscles and joints, allow them to explore but keep them safe. These kids shouldn't be playing contact sports. Soft bristled toothbrushes and no aspirin. Of course, we don't give aspirin to kids anyway. When you have a bleed going on, they get the factor they need. Rest, ice packs to the area that has been bruised. Compression, elevation. Remember rice, rest, ice, compression, elevation. Oftentimes they need a joint aspiration. The doctor or the nurse practitioner will go in and use a needle and draw blood off the joint. And then physical therapy. And we talked about replacing. They're talking about gene transfer as a treatment, a permanent treatment for hemophilia. Still in the works. Last but not least is von Willebrand disease. This is a milder form of what we think of as hemophilia. It's the carrier protein for factor VIII is deficient, and so you don't give them factor. We actually give them DDAVP. It can affect both men and women, boys and girls. Usually what we'll do is treat them with, if they are going to have surgery or a dental procedure, they will come in and get DDAVP before they have that. That's desmopressin. It's also used for children who have incontinence issues. So interesting, isn't it? True or false? Nurse care for a child with hemoglobinopathy in which red blood cells do not carry the normal adult hemoglobin but a less effective type is called ITP. Well, no, no, no.